Hello. Good afternoon. Oh gosh, something just happened here. Trying to go live on this other side, but it did not want to work. Good afternoon. I am Dr. Randy Fink live from CNY Fertility in Colorado Springs. And let's see. Okay, there we go. Now we've got another Instagram that went live. Hey, how you doing? It's that time, 4 o'clock in the mountains, which means 6 o'clock on the East Coast and 3 on the West, 5 o'clock in the Central Time. And there's one place that you need to be right now, and that is CNY Fertility in Colorado. Fertility with Fink and Friends. I am Fink. You are friends. And this is the place that we meet every Tuesday afternoon at this time where we can talk about all those things that are most important to us. And that is things about making your family, things about women's health, things that we all know we need to be talking about today. We've got Facebook and YouTube and LinkedIn right over here. And we've got a couple of different Instagram feeds. We've got CNY right here. We've got my Instagram, Randy Fink MD. Good afternoon to everybody saying hello. If you joined us last week, we were live from Denver at the American Society for Reproductive Medicine, where we had our annual conference. And I really had the amazing privilege of being able to be in a room with three of my most favorite colleagues here from CNY, and really truly an awesome place to be. It was a great show. Got to hear some ideas and things coming from some of the other colleagues. Dr. Kiltz was here from Syracuse and Sarasota. We had Dr. Ditkoff from Albany, Dr. Chang from Buffalo. Really, it was an amazing. I thought it was an amazing experience for us all to be there. It was even more amazing to kind of be in the room with those guys. I want to say a little happy thank you to the signage behind me there. That comes from Brandis, our wonderful nurse practitioner here at CNY Fertility Colorado. And if you're on Instagram, it looks backward. You can't see it there, but I think you can read backwards. Fink and Friends is what the sign says. My new little neon sign in my office here, and it's right below the wonderful signage that came from Jody O, who is our embryologist at CNY in Sarasota. So thank you guys so very, very much. How awesome it is to be here. Let's see who is with us. Got a lot of folks who joined here on the CNY side. Erica Elissa, it says, you are our first to join on the Instagram side. Humbly sophisticated 6036 Jenny. Hello, October Sky. Shay Dunn. Siciliana Melissa, good to see you here as always. Shay says hi. Noodles for Life, Sharmila, hello. It's nice to see you here. Hi, Jenny. Good to see you as well. Thank you for watching last week. Barbara and Emily Fate. Let's see. What else we got here? Amanda, Crystal, Rented Luxuries. Oh, I like that name. Let's see what we got. Zenaida is over here from Miami. Good afternoon. Lainey Kaufman. Our first to join was Siciliana Melissa over here on my Instagram. Thank you. Carly Merchant, Michelle Marks. Hello, Easy E113. Scarlett, hello. Avery Blues, Bethany Soberg, Mariah Wagner. Let's see, and on the Instagram side, looks like Liz Fisher is number one. We've got Vilma and my friend Stardust. Hello, Stardust. Tina Coltrane, Victoria, and Rachel are all here. Let's dive into some questions and see if we can't get some answers done. Hey, happy Halloween, by the way. Are you going to be dressing up? If you remember last year, I was the ringmaster. I think it was on a Tuesday. Yeah, it was, because I think I did my live that night wearing my big ringmaster hat. Everybody gets dressed up here, and not sure what I want to do. That maybe, being a cowboy is always very easy because I can put on the big hat, strap on a gun, and wear some fancy Western clothing. But yeah, I don't know. I saw some really fun costumes. The best one was this thing that looked like a toilet, with your legs are coming out and a toilet in front. I thought that is a little tough to do retrievals in. Plus, typically with a toilet, of course, you do a transfer. But Oh yeah. Oh no, 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 Fink, no. So I don't know, but if you're going to dress up, take some pictures and send them to us because we love to see them, just like we love to see the pictures of your family as it grows and everything that we've been able to do to help you out. So let's see. Sharmila is asking about thyroid. T3 is 55. That's fine. TSH is 2.75. So we look to try to optimize for fertility. We look to have the TSH between 0.5 and 2.5. However, there is some recent data that was just presented at the American Society for Reproductive Medicine that said that those numbers really may not be as important as we thought they were. As long as the thyroid is within the lab's reference range, which is usually going to be less than 4 for the TSH, it's probably okay. However, Sharmila, given the way that we practice right now, I would say if your TSH is 2.75, I would increase your thyroid, your levothyroxine by 25 micrograms to bring that down between 0.5 and 2.5. That's currently the way we transfer, but as I said, there may be some changes in the way we look at thyroid. That's what we know is optimized for fertility. And is that okay for embryo transfer? Yes, I do think it is. But nevertheless, if that came across my desk, I probably would increase it just a little bit. Let's see. Silly32 says, how soon can you do another FET after a miscarriage at 6 weeks? Well, I sure am sorry to hear about that pregnancy loss because that is never an easy thing to have to deal with. And so our thoughts certainly go out to you. How soon can you do another embryo transfer? Well, I like you to have your first normal period after that miscarriage. And so there's some data that shows us that if we go into an embryo transfer immediately after a miscarriage without having that first normal period, there may be an increased risk for subsequent pregnancy loss. And so I like to see you have that first normal period, and our prayers and thoughts will be with you there, my friend, for sure. Brace face tiara. May I know why I need approval from my PCP to start IVF? Well, on certain occasions, we ask for medical clearance, and that would usually be if you have some significant underlying medical problems or if you've had a series of significant surgeries that may have some effect on particularly things like the cardiovascular system. If you have a poorly controlled high blood pressure, we want to get those things all brought into control. But generally speaking, we don't ask for a medical clearance unless there really is some significant issue, and it's usually something that's related to the cardiovascular system. So I think in your case, Tiara, it has to do with whatever your personal history was, made us just want to say, well, you know what, let's make sure that you're healthy enough for pregnancy so that we can move ahead and get you there. Crystal asks, what does it mean when my testosterone is a 6 and my DHEA is 59? I have my third retrieval in December. Okay, so DHEA is tested in the blood as something that's called DHEAS, is technically what the blood test is called. There is pretty good evidence that in women with a diminished ovarian reserve, that is to say an AMH level that's less than 1, that taking DHEA to really boost those levels, even as high as, in the 600 range, is helpful for egg quality. So I would say if you're at a 59, you're probably taking some DHEA, and I think that's fine, but I think you do have some room to grow. DHEA is a pre-hormone before something becomes testosterone. Testosterone used to be something that we looked at pretty regularly as far as replacing in women with a lower ovarian reserve in order to improve egg quality. But the data really hasn't borne out on that using testosterone or something like androgel for testosterone replacement during a stem cycle hasn't truly been shown to make a big difference in outcome. So usually we don't do that so much anymore, except in kind of specific circumstances. but the DHEA, what that tells me is that you still have some room to go up. Crystal, I don't know what your AMH is off the top of my head, but if it's below 1, then I'd say 25 milligrams 3 times a day is really the recommended dose of DHEA supplementation in women with that diminished ovarian reserve. Let's jump over here to the Facebook side. Liz Fisher says, my question today is, tips and tricks and supplements for hair loss. I have PCOS, so I'm no stranger to hair loss, but since my miscarriage in late August, my hair is coming out in handfuls. Since stopping all the hormones is when I noticed the increase in hair loss. Okay, so hair loss is a very common thing. It's also common in women on hormone replacement therapy. So most commonly, what causes this? Truly, it is probably caused there, Liz, by something that is known as telogen effluvium. Telogen effluvium. What does that mean? Telogen effluvium. Well, hair grows in 5 different phases. And let's just call them 1, 2, 3, 4. And the last one is telogen effluvium. So normally, if I were to reach in here and yank out, let's say 5 hairs, I would find that one of each hair is in any one stage at one time. So one hair is in the falling out stage, but the others are in those 4 other stages of growth. Well, telogen effluvium happens when all the hair goes into that falling out phase, that instead of all hairs being in different, for 20% of them being in each one phase, that for some reason they go and they shift so that they're all in this phase, and then they're all in this phase, and this phase, and this phase, and ultimately the falling out phase. And that's known as telogen effluvium. It is typically self-limited. It will last for some period of time, and sometimes that period of time can be a week, it can be a couple of months. It's usually not more than a couple or a few months. That's what we expect from telogen effluvium, and that likely has happened since the stress your body went through from the miscarriage. Any stressor event can cause that to happen. For example, we often see it after childbirth. We see it in folks who have been kind of hormone starved and start on their hormone replacement therapy. So telogen effluvium is probably what that is, Liz. In the meanwhile, what can you do? Well, there's probably 2 things that may help you. One is, well, probably 3 things. One is a prenatal vitamin. So if you haven't taken a prenatal vitamin before and you're taking it now for the first time, what you'll probably end up noticing is that, wow, my hair and it got really shiny and my nails got really strong. So the prenatal is really good for hair and nails. People talk about biotin for hair. I don't find that it really makes that big a difference, so I usually don't recommend it. But there are 2 over-the-counter things you can do. One is Rogaine shampoo, which is minoxidil. Rogaine for women in particular, if you're female, and Liz, you are, I would say is very helpful. It helps prevent hair from falling out, and it does also help to spark some hair regrowth. The problem is that when you stop it, that effect goes away. However, since that telogen effluvium is self-limited and it's going to go away on its own accord, that's a good way to kind of temporize things. And for folks who just have thin hair to begin with, Selsun Blue or Nizoral shampoo, which is ketoconazole. Nizoral, it's a dandruff shampoo. Dandruff is also something that's known as seborrheic dermatitis, but ketoconazole, which is the antifungal main ingredient of Selsun Blue or Nizoral, and Nizoral is really the one that I would recommend, has been shown to also help to prevent hair loss and increase hair regrowth. So we've got prenatal vitamin, minoxidil or Rogaine for women or men, and Selsun Blue or ketoconazole Nizoral shampoo. Those would be my recommendations. Let's see. Hi to Tina. Glad you're here. Victoria asks, if I want to transfer in December, should I reach out in November? Well, so we'd want to know that you have by the way, what I'm seeing here is that I'm getting a a ray of sunlight right into my face, and it's like right into my eye, and it's making me feel very spooky. But sorry if that's bothering you. I'm trying to get out of that sunlight. So we want to know that you have a plan in place for your embryo transfer when that time comes. So if you don't know that there's a plan in place, yes, reach out in the month before, because there's going to be medications that we want to get into your hands. And if you don't have them, the sooner you get them, the better off you are. What I wouldn't want you to do is say, okay, you're going to notify us on December the 1st that it's the first day of your period, and then we're going to need to be starting something really quickly, and you have to wait for somebody to get back to you, and then you're kind of struggling to try to get all the meds in hand in a timely fashion. So I would want to make sure that you've got your meds in hand. So yes, ahead of time is probably a good idea. Rachel asks, what do you, oh, by the way, I do want to mention this. If you didn't get the email or you're not familiar, if you're planning to do an egg retrieval in the month of December, please know that if you are thinking of doing PGTA, which is our pre-implantation genetic testing for aneuploidy, test to see if you have a chromosomally normal embryo, the laboratory that we use, which is called Cooper Genomics, is they shut down for part of the month of December due to staffing because of the holidays. So between, I believe it's December the 4th and maybe the 5th, and December the 25th, CNY Fertility will not be doing cycle stimulation starts for folks wanting to do an egg retrieval with the intention of doing PGT testing. And that's because once we get those embryos, we can't biopsy them and hold the biopsies. The biopsies have to be sent fresh to the laboratory. And if the laboratory is closed, it's a no can do. So please be aware of that. Check out CNY's website if you want more information on that one. Okay, what do you recommend for another transfer after a chemical euploid transfer? That comes from Rachel. So a chemical pregnancy means that you got pregnant, that the embryo was able to grab a hold, but it just wasn't able to stick. It wasn't able to keep a hold. Most of the time, if that happens the first time, we conclude that that is really an embryo issue. It is probably not a mom issue. So that first biochemical pregnancy is usually related to something pertaining to the embryo. People want to know, but I tested the embryo and it's a euploid embryo. It's chromosomally normal. How can you conclude that it's a chromosome problem? Well, you know, people can still miscarry with euploid embryos. And how does that happen? Well, it happens because we're able to test the chromosomes. You know, we can see that the chromosomes are normal, but that doesn't tell us anything about these millions of little chemical reactions, the biochemistry of what's going on inside that embryo to know that the embryo is normal. So any one of those things goes wrong and the embryo will stop growing. So that's likely what happened to you there, Rachel. Pardon me for yawning. Oh my goodness. Whew, geez, that time of day. The good news there is that euploid embryo of yours had a 65% probability of pregnancy. And by the time you go to transfer embryo number 2, you're at an 88% probability of pregnancy. So even though you had a chemical pregnancy with that first one, odds are very high that with the next one, you will have an ongoing pregnancy. So fingers crossed. Mitochondria replacement. I heard you in a prior episode say that some patients tried but weren't successful. Can you elaborate? Well, mitochondrial replacement therapy is something that is investigational and is not approved in the United States. I know of 2 places that it can be done. One is in the Bahamas, and the other, I believe, is in Cyprus, if I'm not mistaken. I just haven't had anybody who was successful with it. I've read some isolated reports of successes, but I haven't had anybody who's gone to do it. That may be because, well, it isn't approved in the United States. It's still kind of, it's still experimental. And this is really for folks who have a lower ovarian reserve and who have DNA issues in their eggs. Basically, the mitochondrial DNA are what creates the source of energy for a cell. And by theoretically replacing that DNA, it may allow the cell to behave as though, or the egg, as it were, to behave as though it were younger. Not a lot of data on it just yet, so hard for us to really say that it's a great idea. It's also pretty expensive because you have to go to either the Bahamas or Cyprus to do it. But that's kind of been my experience with that, Velma. Karina asks, I have my first egg retrieval is coming Friday or Saturday. What should I expect? Gosh, I'm so nervous. I have always wanted a fresh transfer, but what do I need to qualify for fresh? So when you are going to do a fresh transfer, we want to know that your estrogen level, the estradiol, is generally less than, let's say, 3,000. When the number gets higher than that, what it suggests is that your endometrium, or that the lining of the uterus, may not be hospitable to receiving the pregnancy. We also want your progesterone level to be at a 1.5 or really below a 1.5. Progesterone controls the implantation window. So when the progesterone gets high, literally what that means is that the progesterone window has closed and that your transfer will probably not be successful. So for a fresh transfer, we want to know that your body has not been so much into egg making mode that it makes the getting pregnant part of it not something it wants to do that month. And that's what those hormone levels show us. I think as far as egg retrieval goes, you don't have to worry. It's a pretty straightforward procedure. The anesthesia is very, very safe. You will not feel any pain. In most, really all of our facilities, you'll find everyone to be very friendly. It should be a good experience for you. Now, afterwards, I recommend that you plan to go take a nap. And hopefully then by dinner time, you should be fine to kind of plan to go get something to eat. Take it easy. You're going to be a little sore, a little slow moving, probably a little bloated, but certainly able to go get a little something. And if you're coming from out of town to one of our facilities, we want you to take the opportunity to do a little sightseeing, get a change of scenery, and let that add to the whole adventure of building your family. Let's see on the Fink Instagram here. We've got Easy113 says, can you tell me about the FET process and how far in advance I should plan for it? Well, so like I said, we really want you to have your plan in place beforehand, because usually what happens is that you will notify us on cycle day 1, and that's when the process begins. You'll get your baseline. You'll start on whatever therapy we're doing with your FET, whether it's a medicated or a programmed cycle, or if it's an ovulatory cycle, which is what we call a natural or sometimes a modified natural cycle. I do want you to touch base in the month before to make sure that your medications are there, that you have them in hand, and it takes all the stress out of when that cycle is going to start. Now, there are 5 supplements that are part of the evidence-based protocol you should be on when doing an embryo transfer. 5 supplements. What are they? Well, if you forget this, you can go to my Instagram. There's a link tree and my bio. Click on that link. There is an ebook I wrote on this very subject called The Vitamin Victory. It's cheap. It's $7. It includes a coupon that gets you about $25 off these supplements. But 5 supplements you need. One is the prenatal vitamin. Okay, should be taking a prenatal anyway. Vitamin D, vitamin E, CoQ10, and an amino acid called L-arginine. Those are the 5 things that you should be on. You can check my link there at Randy Fink MD and see exactly what those doses are. So that's really all you have to do, Easy, to prepare for your FET. Avery Blue says, thoughts on Lovenox and prednisone, currently on both after a letrozole cycle and a trigger shot. Also, thoughts on these follicle sizes, 14, 15, 20, and 25. Well, so You're doing a letrozole cycle, which leads me to think that you are doing either a timed intercourse or an IUI cycle. So if you were going to be doing IVF, usually we think about Lovenox and prednisone for sure in our transfer cycles. If you were doing IVF and you had those 4 follicles, 14, 15, 20, and 25, I would say, well, I think we're probably going to end up losing that 25 millimeter follicle because the 3 other ones, the 14, 15, and 20, have a little bit more to grow. So the 14 and 15 for sure, I think we'll be able to keep that 20 and get the 14 or 15 to grow a little bit bigger so that we can perhaps get 3 eggs instead of just the 20 and 25, which would be if we retrieved or triggered right now, we'd get those 2 eggs. I'd like the 14 and 15 to grow a little bit more just so we can try to maximize the yield. H. Shu says, I've had 2 successful day 3 fresh transfers, but 3 failed transfers. What would be the reason? If you have had 2 successful day 3 fresh transfers, but 3 failed transfers, well, I think you mean that 2 transfers were successful, but 3 weren't. If that's what you're asking, what's the reason? Well, really the most common reason for an embryo transfer being unsuccessful has to do with the embryo itself, especially with a day 3 embryo, because we don't know a lot about that embryo. We don't know if that embryo would otherwise continue to grow, if it would become a blastocyst, if it has the chance to be a normal embryo. By the time an embryo becomes a blast, which is typically day 5, it is what we would consider to be a little functioning factory. A day 3 embryo is still a group of cells that are trying to divide, trying to figure themselves out, and trying to determine whether they're able to grow. So when we transfer day 3, it means, well, at least we're getting an embryo inside of you where it may stand a better chance inside of you than it would, in the laboratory. You're always going to be a better lab than anything we have here. But most of the time when embryo transfers are unsuccessful, we consider that to be likely due to an embryo issue. And I would suspect if there were day 3 embryos, it's just because we don't know what was going to happen to those embryos if they have the potential, if they're normal enough to continue growing on their own. Scarlett, the realtor, says, how long after removing an ovarian cyst for surgery can I do an IUI or IVF? Really, probably even the next month. It just depends on how difficult the surgery was. If this was a difficult endometriosis surgery that required a big excision, it may take a couple of months for you to fully heal. But in general, if it was a simple cyst that had to be removed, the very next month, you should be fine to resume fertility treatment. Ryan asks, is from the conference you attended last week, any update on the diagnosis and management of endometriosis, particularly stage 3 and 4? Well, actually, yes. There's always a lot of talk about endometriosis, but there's some newer evidence that actually may show us that endometriosis doesn't have as big a role in IVF outcomes as we originally thought it did. So there may be some changes to practice guidelines coming up. Those things do not move quickly, but there is some newer evidence coming to press that suggests that, yeah, we know that endometriosis can have an effect on a mechanical effect in the pelvis. It can cause scarring. It can cause the anatomy to change such that it makes it more difficult for sperm to be able to meet egg. But what about the rest of the stuff? What about the chemical and the hormonal aspect of the way endometriosis messes with the electric signals going between the brain and the pelvis as far as fertility goes? Those are the mysteries, and we may some authors may have just unlocked some new secrets in that the endometriosis may not be as important as we once thought it was, specifically as it relates to IVF. So we'll see what happens there. Lainey, hi from North Carolina. And let's see, Carly Merchant, how long does Orilissa suppression last? So when we are treating endometriosis, with Orilissa, which is an oral medication that's designed to do that. The evidence shows that we do that for 60 days or 2 months of suppression. Now, in the general gynecology world, where we have, where these medications are more commonly used to treat people's pain syndromes with endometriosis, I would not expect that 2 months of treatment is going to make a dramatic difference in the type of pain that you have from endo. However, as it pertains specifically for embryo transfer, 60 days is the recommendation. And you might say, well, gosh, if 60 days is good, I want to do it for 90 days. I want to do it for 180 days. You certainly can, but the evidence shows us all you really need is 60 days. Let's see what else we got here. Janine Odo, I have a follow-up with you tomorrow. Can't wait. Sending everyone all the baby dust. Thank you, Janine. The baby dust is very helpful. We appreciate it. Lainey says, I'm age 35. My AMH is 1.28, and I've had different providers suggest mini dose or standard. In my opinion, at 35 with a normal AMH, you would use a standard dose therapy. A mini dose therapy would be appropriate for someone in their 20s or someone with sometimes with a diminished ovarian reserve, and even that can be debated. But in your situation there, Lainey, with a normal AMH in your mid-30s, if you used a mini dose therapy, I believe you would be getting yourself fewer eggs than you would if you used a standard dose. So the way we dose these medications is really based on your age, number one. So that tells us how we expect your ovaries to respond. And the secondary measure is with the AMH. So let's say that you were 35 and your AMH was 5. Well, if that were the case, I'd say, oh, I bet you probably have polycystic ovaries. And that means that when I give you medication, your ovaries are really going to respond well to the medication. You might even become hyperstimulated. And so in that situation, I would dial back the dosage. But with a nice normal AMH there in your mid-30s, a standard dose would be really the appropriate dose for you. Let's see. Can you use Rogaine during an IVF cycle? Yes, you can, because it's just topical. Doesn't go anyplace else. Lovely Onyx says, what can I use for backache, abdominal cramps, and leg cramps in the third trimester? It's worse in the mornings. Okay, so you got a couple of things going on there. First of all, with the backache. So first, actually, congratulations on the pregnancy. Gosh, third trimester. That is very exciting news, Onyx. That is awesome. The backache, you got to realize that your whole center of gravity has changed with your pregnancy. So for your entire life, your spine and your hips and your body has been able to keep you walking upright and standing and moving around like every other person on 2 feet. Well, suddenly now you have a big bulge that's sitting out here. And so all these little muscles of your back are having to do work that they haven't really probably ever had to do before. So it's no wonder you have a backache. I think chiropractic care can really help that because it helps to realign the spine and the hips. Because those are the two kind of places that have to bear most of the brunt on that change in your center of gravity. The other thing that happens there with that change in your center of gravity is you become more likely to have a fall. So you got to be careful as you get more pregnant, especially folks who exercise a lot, because the center of gravity changes. And also due to some hormones in the body, the joints loosen. So you may be more prone to injury. Now, as far as abdominal cramping goes, well, you have to remember that you got a couple of things that are causing you cramping. First of all, your baby is in there going, and probably making that noise too. Actually, if you listen really carefully, you can hear it. But the uterus is a muscle, and that muscle is built to do one thing, and that is to squeeze a baby out. So until it reaches the time where it knows how to squeeze a baby out, it's going to be doing a lot of practicing, a lot of this and a lot of that, a lot of just kind of moving around and all that stuff you're going to feel. Additionally, as the uterus grows, it's connected by some ligaments that run down the side. And these are called round ligaments. And those round ligaments can pull, especially in different positions. Like you roll over to your side and it feels like somebody's stabbing you with a knife. I've had people who absolutely are convinced that they have appendicitis because that pain is so sharp, but really it's round ligament pain. So those things are really pretty normal. Keeping yourself extra hydrated can be something that really helps with a lot of the cramps, because when we become dehydrated, we start to make more of a hormone that's known as ADH, or antidiuretic hormone, and that functions very similarly at the level of the uterus as oxytocin, which is what makes you have cramps and ultimately labor. And the last thing is the leg cramps. So why does it happen? Some people say it's calcium. Some people say it's potassium. I've heard people say chew 2 extra Tums a day. Tums is calcium. I've heard people say eat an extra banana a day because of the potassium. I don't know that either of those things really does the best job. Here's what I would do, because I think it's the ultimate cure for those leg cramps in pregnancy. Tonic water. Tonic water. Don't put the gin in it. You're not supposed to do that. But tonic, get a little bottle of Schweppes tonic water, put it in the fridge, because I think it tastes better if it's in the fridge, and drink a little bit of it over ice, because I think it tastes better. And it's a carbonated, sweet, kind of a little bit of a bitter drink. If you've never tried it, it's not offensive on the tongue, but it is somewhat of an acquired taste. But it contains trace amounts of a chemical known as quinine. And that will stop your leg cramps, virtually guaranteed. You don't need to drink a gallon of it. You really just need a little glass, usually better over ice tonic water. So there you go. Onyx, gosh, congratulations on the pregnancy. Can't wait to see your baby pictures there, my friends. JM Dot says, is there a progesterone level that would be considered too low for an FET, or is the optimal range or an optimal range to aim to be in for transfer day? So what we are looking at is really going to be the number, the most optimum number is going to be as it pertains to at the time of your midways and with your beta. If you're doing a medicated cycle, we want that number to be at a 20. If you're doing a natural or a modified natural and ovulatory cycle, we want that number to be at a 10. Now, remember, in nature, if you've ovulated, your progesterone is going to be above about 2.5, let's say, for argument's sake. So honestly, is there a number that's too low? Well, if it's below probably 2.5, it means, well, you didn't really ovulate, or so I'd say something's going on there with that. But the most important number is that 10 and that 20 at the time of your midway and at your beta. So not so much necessarily right then at transfer. Let's see here. I am going back to the medical clearance. I'm anemic and pre-diabetic. So that may be a good reason to get a medical clearance. That if it depends on what you mean by pre-diabetes, sometimes we look at a blood test that's called a hemoglobin A1C. And an A1C is the measure of your long-term blood sugar. So it really tells us what has your blood sugar been over the last 90 days. And if that number is above 5.7 up to a 6.4, that's what I would consider pre-diabetes. If it's 6.5 or above, that is diagnostic of diabetes. So that's probably the reason why somebody wanted you to get a medical clearance there. Yeah, for sure. It's been 8 days. My follicle size is 13. My endometrium is 5.5. What does this have to do with transfer? Well, so if you're doing a natural cycle, we're going to look for you to ovulate when that follicle is probably around 18 millimeters. And by that point, your lining should be a little thicker. 6.5 is really the minimum we would look for. 7 would be ideal, but you're probably 4 or 5 days from ovulation there. And so I think you're going to get both a bigger follicle and a little thicker lining. Better with a bat, says, I believe that says, any suggestions for rashes all over the body with PIO and oral estradiol? My FET is in 2 days. Well, so probably what that is a reaction to something that is in the progesterone, which we see sometimes. What can you do about that? Well, the first thing I would say is that progesterone. Oh, we lost a signal over there. Let's see if we can get our camera back. No, not working there. So we're on Facebook here with audio only. Not sure what happened to my camera. Let's see if I can try to troubleshoot that one. I can't even really see it over here. Here, bear with me. Start cam. There we go. And we are back. Sorry about that. Hello. All right. I was saying the progesterone in oil, it may be that you're allergic to what's in the oil. So you can have a different oil compounded. Ethyl oleate is usually what we would go to next. There has been more talk about an oral type of a sublingual type of progesterone. That is to say, not a pill that you swallow, but one that's absorbed through the skin of the mouth. That may also be useful. There have been some studies on it. It is something that I'm looking into because I'd like to know, hey, the progesterone in oil is still the standard in a medicated cycle, but nobody likes that shot. And for some people, a natural cycle may not be the right choice either. Can we do a medicated cycle with a type of progesterone that isn't so offensive to your butt? And that would be with this particular type of sublingual, it's called the buccal mucosa. That's through the gums is where it's absorbed. I'm looking into that. Hopefully I'll have some more information on that next time. But I would suggest maybe you think about changing the PIO you have to ethyl oleate if somebody came to me and said, hey, I'm having this rash. What should I do? Jenny says, my donor is scheduled for a retrieval next week. How soon can I do an FET provided that there are embryos? Is there a possibility before Christmas? Yes, absolutely. So if you're having retrieval, they're gonna get those eggs. They're gonna make the embryos. Really, once those are made, if your cycle was synced, then in theory you could try to do a fresh transfer with those embryos, but it's hard to get those things synced together. So the embryo is usually frozen, and then we start on your cycle right away, shutting it down, controlling it, and getting you ready for implantation. But absolutely, yeah, I think you could certainly be doing that during the month of November. So certainly before Christmas for sure. Zari B says, here's a quick question. Recently, 5 embryos transferred, just had a biochemical pregnancy. Would you think this is related to not having the embryos PGT tested, or could it be my endometriosis? Well, that is a hard question to answer because, endometriosis can certainly stand in the way of implantation, as we discussed. PGT testing only takes a group of embryos and helps us to determine which of those embryos are chromosomally normal so that there are fewer unsuccessful transfers. That's really what we're after by doing PGT. Even a PGT tested embryo can still get you a biochemical pregnancy. But my guess would be that if you had PGT tested those 4 other embryos that didn't result in any positive pregnancy test, we would have learned, well, are any of them actually chromosomally normal? Because with that first chromosomally normal embryo, 65% probability. 88% probability of pregnancy by embryo number 2 and a 95% probability by embryo number 3. So hopefully that's helpful there. Amanda says all of my doctors, including Kiltz and my European team, were there, I guess, at ASRM in Denver. Yeah, we had a good time. Rosa SD, 42-year-old, recently have a high level mosaic embryo. Is there any hope for this embryo? Can it be transferred and work? Absolutely, yes. Yes, it can. So your mosaic was in chromosome 19. So let's talk about mosaic embryos because it's not an uncommon finding when we do PGT testing. What is a mosaic? Well, first of all, actually, before we do that, let's take a quick moment to say it's a quarter till the top of the hour, and you're on Fertility with Fink and Friends. I am Fink. You are friends, and it is great to be here like every Tuesday evening. We got about 15 more minutes. Let's see what we can get done here, folks. A mosaic. So when they're doing the embryo biopsy, they are biopsying the portion of the embryo that becomes the placenta. In the embryo, that's known as the trophectoderm. They're biopsying the portion that becomes the placenta. And as you know, we have two sets of chromosomes to equal our 46, two sets of 23 or 46. A mosaic means that a portion of those two sets, usually a portion of one set of those embryos, is found to be abnormal, at least so much as what is in the placenta. Now, a euploid embryo, or one that is chromosomally normal, has about a 65% probability of getting you a pregnancy. Depending on how old you are, let's say that you're, Rosa, you're 42, but let's just say let's make it, let's say that you're 38. Okay, if you're 38, you've got about, if you have an untested blast, you have about a 30% probability of a pregnancy with an untested blast. Your mosaic embryo there gives you about a 40% probability of a pregnancy. So it's not as high, it's not as good as you have with a euploid embryo, but it's still better than what you would have with an untested embryo. So there is a slightly higher risk for a miscarriage, but if those embryos implant, then and continue to grow, then they have every bit the same probability of giving you a normal baby as does your euploid embryo. So, and in fact, they just published some data on that, looking at a bunch of different outcomes with mosaic embryos. Kids do the same. They reach the same milestones. The APGARs are the same at the time of birth. There's no difference really in a baby that comes from a mosaic embryo than you would see with a chromosomally normal embryo. So does it have a chance? Yes, it does. Now, as we mature, as our age goes up, we don't do as well with those untested blasts. So by 40, that number is getting to be closer to 10%. By 41, 42, it's closer to 5% with an untested blast. So in that situation, even still, your mosaic embryo has a remarkably higher chance of giving you a baby than does your untested blast. How about that? Yeah, so there are a lot of practices that say, oh no, we destroy those mosaic embryos. Well, I think that's a big mistake because mosaic is not a throwaway embryo. Let's see, back over to the Facebook side. Olivia says, where'd you go, Olivia? There you are. How do you feel about day threes? What would be the best transfer protocol for a 27-year-old with PCOS? We're transferring our last two in January. All my labs were good when I went through it in April. I ovulate on my own and my cycles are regular. So I really do, as we talked about a minute ago, I really do like a modified natural FET, especially with the PCO. I think using the modification of ovulation induction, we give you a little letrozole to make sure that you're going to make an egg, and a trigger shot. I think that's both a very good idea. They say that there's not a big difference between outcomes with a medicated cycle versus a natural cycle. So, is there a difference choosing one over the other? There shouldn't be, but personally, I think that the natural cycle is just easier on your body. Plus, you're using hormones that your body makes by itself anyway, and you do that every single month. So I think it's very reasonable to want to use them, especially in your situation. Now, a day 3 embryo, there is nothing wrong with a day 3 embryo. If you grow that embryo to a blastocyst, then that blastocyst has a higher probability of getting you pregnant because it has made the transition between a bunch of cells trying to divide and a little functioning metabolic factory. So that's a good thing. But is there a problem with the day 3? No, absolutely not. Again, get that embryo inside. If that's what you have, put that embryo inside of you. It does mean more possibly unsuccessful transfers because we don't know if that day 3 embryo has something wrong with it that wouldn't otherwise continue to grow. But even if it did, maybe it will grow in you. Our human bodies have DNA repair mechanisms. So maybe there's something about you that will let that embryo grow, whereas it might not have grown in the lab. So do I like day 5 or blastocyst embryos? Yes, because they're kind of more reliable. But is there anything wrong with a day 3? If it's going to work, it's going to work. So yeah, you go for it. And I would say in ovulation induction with letrozole and a trigger shot. And that's how I would do that ovulatory or a modified natural FET. Tracy Allen says, I am anxious about the egg retrieval in a couple of weeks. What days are we notified with updates on embryos, and how long does it take to hear back with results from PGT? Well, naturally, it is absolutely a nerve-wracking situation. 100%. Yeah, it really, really is. What happens is that day of your retrieval, we will know how many eggs. The next day, we will know how many embryos. Once we have a plan in place, which is confirmed at the time of your retrieval, and then again the next day when you get that fertilization call, after that, you won't hear anything from our labs. They will not give you an interim update. Why not? Well, because they don't want to mess with these embryos. They want to let them grow as best they can without taking them out to look at them and inspect them and try to grade them and get some subjective information that really won't change anything except that it might hurt the embryo. So you won't hear anything until the end of that period when you will get a report. So you're growing out to blast. It may take a full 8 days before you get the report because a blast, an embryo can become a blast up to day 7. And then the next day after the last one is biopsied and frozen is when you will get your written report. Right now, it's taking 10 to 14 days to get those PGT results back. And when those results come back, you will get a phone call from one of our embryologists who will go over those results with you and answer all your questions. But the freeze-all report that you get after they're biopsied and frozen has pictures, it has the grading and explanation of the grading, basically everything except for their names, because that part's up to you. 10 to 14 days for the PGT, and then you'll get a phone call. Good luck, Tracy. Couple of weeks. Can't wait to hear what happens. What medications are required for a fresh transfer? Well, really the most important medications there are estrogen and progesterone. That is the cake. There's icing, and the icing is what we do for the immune protocol. But the cake part is, where do you get your estrogen? Where do you get your progesterone? We're either giving it to you in the form of estradiol and progesterone in oil, or if you're doing a natural cycle, your body is making that itself. So that's really, those are the only two things that are really truly required: estrogen and progesterone. Haley Evans says, thoughts on Prograf through 12 weeks. I've read it's not good to take while pregnant. No, it's fine. It is fine to take while pregnant. And in fact, we're recommending it through that first trimester. The original data on why we've started using it came from folks who had poor pregnancy outcomes, and they found that women who had kidney transplants who were taking Prograf did surprisingly well with their pregnancies. So for a short term, I mean, honestly, even if you needed it for a long term, I think it's fine. But certainly through that first trimester, there is no meaningful association with any bad pregnancy outcomes. And in fact, it may just alter a bad pregnancy outcome. Dr. Anadra says, good evening. I'm scheduled for egg retrieval Friday or Saturday. How do I avoid OHSS after the procedure? OHSS, or ovarian hyperstimulation syndrome, is really something that arises as a result of the stimulation itself. So the best way to avoid it is to be careful with the stimulation. Now, sometimes it can't be avoided in the system that we have here. So what can you do to try to help? Protein, protein, and more protein. 200 grams of protein is really the best thing that you can do at home. Why protein? And how do I get 200 grams of it? 200 grams is a boatload of protein. That's a lot of protein to have to consume. It's a lot of protein drinks that are disgusting. And you're probably full, you're not thirsty, you're bloated, and you don't feel great. And you don't want to be drinking, 8 protein shakes. But to the best of your ability, the best you can in a high protein diet, because protein convinces your kidneys to help get rid of some of the extra fluid that your body retains that is part of the mechanism that makes you sick with OHSS. Now, OHSS itself typically does not really start to peak until about 5 days after an egg retrieval. And that's when, we really start thinking about the electrolyte imbalances and the fluid retention. But best thing you can do ahead of time is protein and electrolytes, and to avoid OHSS by your stimulation. All from the get-go. Kristen says, I have my very first egg retrieval tomorrow. Best of luck. 26 years old with a low AMH 0.53. I have 10 follicles that look nice, so we're hopeful that there will be some mature eggs in there, but that can turn into at least one embryo. We will hope so as well. I will keep my fingers crossed there for you. Sometimes follicles can have more than one egg. Sometimes they can have no eggs. So I always tell people, don't hold on to any number when you're going into that retrieval. Why not? Why or why not? Well, because the number doesn't necessarily mean that's how many eggs you're going to get. There may be way more follicles than what they reported, or there may be fewer. Sometimes those follicles don't have eggs in them, or sometimes they have multiple eggs. So whatever's there, we're getting out. There is no egg left behind. So you can be very confident that if it looks like a follicle, we're going to put a needle in it and try to aspirate out an egg. So best of luck there, Kristen. Let's see. Does CNY do a vaginal microbiome test? T. Andres is asking that question. No, we do not. However, there is a personalized microbiome test that I would recommend if you would like to do that, and that's called EVVY. EVVY. EVVY is a vaginal microbiome test that will test for your very personalized vaginal flora, and then make recommendations with a personalized vaginal probiotic in order to be able to restore an optimum microbiome. That's called EVVY, EVVY. They have a nice website, so take a look. Hello to Alexis in Miami. Let's see here. Blaxican Beauty says, what diet would you recommend I start for my FET next month? And does red light therapy have benefits for an FET? They say it does, but it's experimental and the evidence is not overwhelming. So I would not spend thousands of dollars on red light therapy. And as far as diet goes, we recommend keto. Keto is high fat, moderate protein, low carb. And if you're not familiar, Dr. Kiltz's sentinel work is actually on the far end of keto, which is now carnivore. Certainly take a look at some of the stuff he's done, because he is really an authority in that field. Somebody said, oh, Avery Blues, timed intercourse between IVF cycles. Yeah, you could do that for sure. Hi to Angela in Minnesota. Wide River, how long does the suppression benefit last you after you stop or listen? Well, we don't know the exact answer on that, but I would think it's probably about 6 months. There are some people who say it's a shorter period, like 3, and there are some people that say 9 to 12 months. They haven't really tested it. River. So it's hard to say really for sure. But in my opinion, 6 months feels like kind of a safe bet there. We'll get one more here from Nick Batez. Second transfer failed. We did an endometrial scratch and PRP, an HCG wash, lipids, and carnivore this time. Anything I should add using the vitamin Victory and carnivore? So good. I was going to say that means the 5 supplements for sure. Nick, I'd want to know for sure that your uterine cavity has been evaluated either with a saline sonogram or hysteroscopy to make sure. But it sounds like you're doing all the right stuff there. I would certainly just add Prograf, which is 3 milligrams in divided doses. So either 1 milligram 3 times a day or 1.5 twice a day, depending on how you want to do that. We are about out of time here, friends. And as always, it is such an honor to be able to be here with you and for you to spend your valuable time with me so that I can try to share some of the things that I've learned over time with you, because that really is what makes my entire week. It truly is to see your names showing up here. It shows me that you care. And more importantly, honestly, you care about each other. I love the way people answer other people's questions. It's really a fantastic thing. It's a wonderful place to be. This whole fertility business is not the book of your life. It is not your novel. It is merely a chapter. And what are we here to do? We are here to rewrite it together. Every step forward with kindness to each other, with love, and with the hope, because tomorrow is a new day. It brings all new things. So keep your chin up. It's tough business. It's a tough place to be. But I am Fink. You are friends, and God bless you all. Thanks so much for being here. We'll see you next week.